Okay, great. Okay, Dr. Fanari, transcatheter management of aortocoronary saphenous vein graft aneurysm using a Viabhan covered stent.
Thank you very much for inviting me to present here today. Actually, after these cases, I feel a little bit overwhelmed because I'm not going to present something as interesting as this, but I thought it's still something, a neat concept that actually I saw actually more than once. I did this case, and since I did this case, actually I did 2 other cases, less complicated, so I thought it might be nice to share it with everybody. I want to thank my collaborator in this case, Dr. Sandra Weiss. So this, we got a patient, actually, a 66-year-old who presented, had history of CABG when she was actually in her 40s, with lima to LAD and saphenous venous graft to the RCA, who presented with severe chest pain and shortness of breath, with non-STEMI, complicated with congestive heart failure. In physical exam, actually, we heard this very weird to and fro murmur in the mid of the sternum, which is very weird side to hear a murmur. And we couldn't really know before we took her to the cath lab what this murmur is about. So we went to the cath lab, and this case was done 2 years ago. So unfortunately, I don't have the videos, but I think the pictures will be will show it enough. So when we injected the graft, as you can see, there's a vein graft. You can see the vein graft, and you can see there's aneurysm. You can actually see a flow to the right atrium. And what you can notice also there, you can notice a swan catheter there. So we actually did right heart measurements when we did this, and our air pressure actually was 85%, which talks about a huge shunt, obviously. This is actually, so at this point, we wanted really to see what we were going to do, so we stopped. We assessed this with a CAT scan. You can see actually the size of this aneurysm is almost 3 by 3. You can see this part of it is thrombosed already. So in this next image, if you look at the contrast very carefully, you can see actually, you almost can see the flow from the aneurysm to the right atrium there, actually. So, as I said earlier, actually, when we did the assessment, we did right heart cath, and the right atrium saturation was 85%. QS was 2.2 to 1, actually. And so obviously, we tried to manage this with heart failure medication, tried to manage the chest pain with medical therapy. Unfortunately, that didn't work. She actually, on exam, she really had, and that actually progressed during the hospitalization, she really had a lot of volume overload, actually. So we discussed the options to do this, and we discussed it with the surgeons. Unfortunately, when we did the CAT scan, the lima actually was running behind the sternum. So actually, any redo surgery was going to cause it may cause severe damage to the lima. And obviously, right now, the lima is giving the LAD, and actually that is supplying the distal RCA. So the surgeon said, we're not going to do this, medical therapy failed, so we decided to do endovascular intervention. So when we decided to do this, we wanted to do 2 things. We wanted to exclude the aneurysm, let it thrombose, and we wanted also to, because of the chest pain, we wanted to maintain the flow distal to the aneurysm. So we thought that a cover stent can be the best option in our case. So the size is really big. We went with IVUS. I don't have the IVUS image, but basically it showed actually when we did the IVUS, it showed that the graft around that area, the graft itself size actually is 5 millimeter. So we decided actually to use Viabhan stenting. So we used 8 French multipurpose guide. Viabhan stents usually need 6 French sheets, which correspond to 8 French guide size. I'm sorry, actually we decided to use 6.0. So it was 5.5, so we decided to go a little bit higher size with the Viabhan. So we wired originally with 0.14 wire and then exchanged to 0.18 using a quick cross. However, in the next 2 stents, I tried to go, next 2 cases I did after this, I was actually able, if the angle of the guide in these grafts actually is good enough, you can even go with the Viabhan over the 0.14 wire. So we actually did the first stent. We both dilated aggressively. We still have some flow, as you can notice there. And we were, I think at this point, we thought maybe the neck of The neck of the aneurysm is a little bit bigger than what we thought, and it's a little bit extending a little bit more proximal. So we actually put another Viabhan stent, overlapped with another stent, and both dilate aggressively, and then we got this result that you can see. This is CAT scan done in 3 weeks afterward. You can see it's fully thrombosed now. The only lumen you see there, that's actually the graft lumen. And it's actually smaller. If you remember, it was 3 by 3, it's 2 by 2 right now. So take home message, pseudoaneurysms can be sometimes found incidentally, but they may get complicated. They may actually get the fistula to other organs, or they may decrease the flow to the territory and cause ischemia, and it can be symptomatic. Endovascular repair is feasible. There are many options, including using occluders. In this case, as I said, we wanted to maintain the flow to the distal vessel, so we used covered stent. Thank you very much.